Welcome to today's session on medical case management, HIV guidelines, and antiretroviral medications, Part 1. This is being presented by Dr. Elizabeth Sherman. Dr. Sherman is the principal investigator for the NOVA Southeastern University Local Performance Site of the Florida Caribbean AETC. She is also an assistant professor of pharmacy practice at NSU. She provides HIV/AIDS pharmacotherapy trainings for the Florida Caribbean AETC. Dr. Sherman works closely with a multidisciplinary team of infectious disease clinicians as a clinical pharmacist with expertise in antiretroviral resistance, drug interactions, and medication adherence. I am now going to turn the session over to Dr. Sherman.
Thank you for the introduction, Suzanne, and welcome to everyone who's listening in. Again, my name is Elizabeth Sherman, and I'm an AETC faculty member. I'm an HIV clinical pharmacist with the Memorial Healthcare System and a faculty member in the College of Pharmacy at NOVA Southeastern University in Broward County, Florida. And this presentation is part one of a two-part talk entitled HIV Guidelines and Antiretroviral Medications. This slide set has undergone peer review, and I have nothing to disclose and no conflicts of interest to report. There are 5 objectives for this presentation, and they're listed on this slide. And by the end of the talk, we will have covered information pertaining to the Department of Health and Human Services Adult HIV Treatment Guidelines, also known as the DHHS Treatment Guidelines, goals of therapy, the importance of adherence, when to initiate ART, and how ART regimens are selected. So let's get started with describing the DHHS HIV guidelines. HIV care in the U.S. is mainly driven by guidelines set forth by the Department of Health and Human Services. The DHHS publishes HIV practice guidelines for adult HIV, pediatric HIV, and perinatal HIV, among others. So on this slide, I've listed for you where to go for more information. The first link is the website where the DHHS adult HIV guidelines can be found. Importantly, these guidelines were recently updated in November 2014, and I would say they're updated about every year whenever there is a compelling amount of evidence to shift the way HIV medicine is practiced. And so the information in this presentation is reflective of the most recent updated guidelines. The last set of published guidelines was approximately 280 pages, so it's a rather large document to say the least. The guidelines do have a table of contents, and the information is written in a very approachable format, but what I intend to do with this presentation, part 1, and in my next presentation, part 2, is to describe those items from the guidelines that are relevant to case managers. The second link on this slide is to the Florida Caribbean AIDS Education and Training Center, which regularly publishes an updated pocket card of antiretroviral therapy. These pocket cards are very handy for anyone working with HIV medications and in HIV care, and they're available free of charge using the website listed here. And now we'll move on to our second objective, to review ARV treatment goals. And before we get to goals of therapy, I think it's important to first remember that HIV is a virus, and it's a virus that attacks our immune system cells. And the cells of our immune system are called CD4 T cells. The HIV virus uses our CD4 T cell machinery to replicate, and once it does this, the T cell dies because our cells are not set up to be mini virus factories. So over time, what we see is more and more copies of circulating virus and fewer CD4 T cells. Now, once a person loses their T cells, their immune system weakens, and they become increasingly susceptible to many opportunistic infections. Antiretroviral therapy works because it stops the virus from replicating, and this suppresses HIV viral load, which therefore results in improvements in immune system functioning. This graphic shows the life cycle of HIV, and you'll notice that the HIV virus first has to enter into a person's own CD4 T cell in order to replicate, and this entire process of viral replication can be summarized in 6 key steps. First, the virus comes along and attaches to our CD4 T cell. Then an entry, the virus dumps its contents into the T cell, and this includes the virus's genetic material called RNA, as well as some viral enzymes. Next, the process of reverse transcription, where the viral RNA is converted to this DNA intermediate. Then integration of the host DNA into our own DNA. then the process of viral transcription and translation, and finally assembly of the immature virion and budding. So this new DNA gets packaged into miniature viruses and is then cleaved off the T cell. These new viruses then go on to infect other CD4 T cells, and this CD4 T cell dies. I use this slide to illustrate for you what happens when a person loses their CD4 T cells. On one axis, we have CD4 count, and on the other axis, we have time as the disease progresses. If a person with HIV infection is not on ART medications, the virus will continue to replicate, and the immune system cells will continue to drop. And as the CD4 T cell counts decrease, a person becomes more and more susceptible to opportunistic infections. So you'll see that with a declining immune system, a person becomes more susceptible to thrush, PCP, toxoplasmosis, among others. But with antiretroviral therapy, CD4 T cell counts can stay high, and a person can remain free of these opportunistic infections. Goals of ART are listed on this slide and include getting the viral load, also known as HIV RNA, to undetectable, increasing CD4 counts, and as a reminder, a person without HIV infection usually has CD4 counts in the range of 500 to 1500, and an AIDS diagnosis is considered a CD4 cell count less than 200. And other treatment goals include improving quality of life, reducing morbidity and mortality, and preventing HIV transmission to others. The way we monitor treatment success is through two surrogate endpoints, viral load and CD4. HIV RNA, again, is also known as viral load, is critical in determining response to ART and may influence the decision to start ART or ART selection. This slide shows how often viral load should be monitored. We check at baseline and before initiating ART. We check 2 to 4 weeks after starting or changing ART, and then every 4 to 8 weeks until suppressed. And then we check every 3 to 4 months in stable patients, although this interval may be extended in stable adherent patients. Every so often, isolated blips may occur. This is when a viral load goes from being undetectable to a small, low-level increase, typically less than 400 copies per milliliter, and then it goes right back down to undetectable. These blips are not thought to predict virologic failure. CD4 count is a major indicator of immune function and is important in determining the response to ART. It is the single best predictor of disease progression and a key factor in the decision to start ART or opportunistic infection prophylaxis. CD4 count is usually monitored at baseline and at least every 3 to 6 months, although again this interval can be extended for patients who are adherent and stable on their antiretroviral therapy. 3 tools for achieving those treatment goals are performing pre-treatment resistance testing, maximizing adherence, and selecting individualized ART regimens. So now let me tell you a little bit more about resistance, adherence, and then we'll move on to the process for selecting ART regimens. Testing for the presence of drug resistance can help plan therapy. Drug resistance refers to the reduction of the sensitivity of the virus to a particular drug. Resistance results from a genetic mutation in viral enzymes and proteins that lead to changes in the ways that drugs interact with them. And there are 2 mechanisms for antiretroviral drug resistance: transmitted resistance and spontaneous resistance. Transmitted resistance is when a person newly acquires a resistant strain of HIV at baseline at the time of infection. This happens in about 5 to 15% of cases. This is why a genotype resistance test is done before initiating ART to determine the presence of transmitted drug resistance. Spontaneous resistance occurs because HIV can develop mutations easily and become resistant. One way to prevent the development of this type of resistance is to keep the number of viral particles low and to be adherent to ART. So, as mentioned before, genotype resistance testing is recommended for all patients at entry into care. Now we'll talk a little bit more about why adherence is so important for treatment success. ART adherence is a major factor in ensuring virologic success and a significant determinant of survival. Adherence to ART has been correlated strongly with HIV viral suppression, reduced rates of resistance, an increase in survival, and improved quality of life. A primary goal of ART is full and durable viral suppression to undetectable levels. For most patients, near-perfect adherence, approaching 100%, is necessary to achieve this treatment goal. The goal when taking ART should always be to maximize adherence. Achieving near-perfect adherence significantly reduces the likelihood of disease progression, AIDS-related morbidity and mortality, immunologic and virologic failure, and drug resistance. Optimal medication adherence provides by far the best chance for long-term clinical success. And adherence is an area where a case manager can make a world of difference. Adherence to ART can be influenced by characteristics of the patient, the regimen, the clinical setting, and the provider-patient relationship. There are many factors that are believed to affect a patient's ability to adhere to a treatment regimen, and some are shown on this slide. These include HIV-related stigma, low health literacy, difficulty taking meds such as problems swallowing pills or an erratic work schedule, active substance abuse, and psychosocial factors. As a result of all of these factors, the decision to start therapy is not always obvious, and it's important to address the issues that may bear on adherence before beginning any antiretroviral regimen. And here I've listed some strategies that medical case managers can use to improve adherence to ART for patients. Patient education should be supported on an ongoing basis. As mentioned previously, regimen complexity and pill burden have been associated with non-adherence. Simplified regimens, such as those that incorporate co-formulated agents or once-daily dosing, are of great help. Clients may benefit from knowledge of possible adverse effects and when they're most likely to occur prior to initiating a new regimen. Case managers can share practical tips and encourage clients to seek attention for issues. Also, a clinic environment that makes clients feel welcome, comfortable, and respected is important. Case managers can assist with reminders of clinic appointments and promptly contacting the patient if the client missed the appointment. Case managers can also initiate calls to patients between clinic visits in order to address possible concerns, particularly following the start of a new regimen. Clients should be encouraged to identify or develop a network of friends, family members, or peers who can encourage or assist them in taking their medication. And lastly, encourage patients to use reminder devices like alarm clocks, cell phone alarms, mobile apps, text messaging reminders, and calendars. Pill boxes are also very helpful. I'd also like to mention that there is a Florida Caribbean AETC Medical Case Manager online module covering the topic of adherence in more detail, and more information on these strategies and others can be found there. Now we'll move on to identifying basic criteria for ART initiation. This slide shows recommendations for when ART should be started. Importantly, ART is recommended for all HIV-infected patients, regardless of CD4 T cell count. Now, the strength of that recommendation varies, and I'm not going to get too much into the strengths of the recommendation, but it has to do with how much evidence we have and how conclusive that data is. And it's common sense. An A1 recommendation trumps a B3 recommendation. But the bottom line here is that all patients with HIV should be started on treatment. This recommendation was made based on increasing evidence that showed the harmful impact of ongoing HIV replication on both AIDS and non-AIDS disease progression, and on emerging data showing the benefit of effective ART in preventing secondary transmission of HIV. But ART is still not for everyone, and a provider may elect to defer ART based on clinical or personal factors, or when there are significant barriers to adherence, or comorbidities that may complicate ART. And with the decision to initiate treatment for any disease state, there are always known risks and benefits. This slide shows the risks and benefits of ART. Risks include the potential for medication-related side effects, which may impact adherence and therefore lead to the development of drug resistance. But the benefits of ART outweigh these risks. Benefits include a proven increased survival benefit, a reduction in HIV-related and non-HIV-related complications, including certain cancers, and a reduction in HIV transmission to others. Now I'd like to focus on the final objective, reviewing the process for selecting ART regimen. Now, I know that case managers aren't prescribing ART regimens, but I think it's important for everyone on the team to understand how these decisions get made about which medications to start for that particular patient. The way an ART regimen is selected is based on a number of factors listed on this slide. We consider regimen efficacy. A typical initial regimen consists of 3 or more drugs from 2 or more classes. Monotherapy is often ineffective to control viral replication. We need to use combinations of medications from more than one drug class. We also consider comorbidities such as tuberculosis, liver disease, depression, cardiovascular disease, chemical dependency, or pregnancy. Comorbidities where there might be potential for adverse effects or drug-drug interactions. We consider drug resistance, so if a patient has transmitted drug resistance at baseline or developed drug resistance on failure. And importantly, we consider adherence potential, so we consider the total daily pill burden, dosing frequency, and food restrictions. We have 5 ARV drug classes, and the classification is based on where in the viral life cycle each drug acts. We have nucleoside reverse transcriptase inhibitors, abbreviated NRTIs, also called nukes. Non-nucleoside reverse transcriptase inhibitors, abbreviated NNRTIs, and also referred to as non-nukes. Protease inhibitors, abbreviated PIs. Integrase strand transfer inhibitors, that we often refer to as just integrase inhibitors. And entry inhibitors. Now we'll go back to the HIV viral life cycle diagram and look at where each of these 5 ART drug classes work. You'll see entry inhibitors work to prevent the virus from entering into the CD4 T cell. NRTIs and NNRTIs work at the point of reverse transcription. They prevent the viral RNA from being converted to this DNA intermediate. Integrase inhibitors work by preventing the viral DNA from being integrated into the host genome. And protease inhibitors work at this final step here, preventing the virion from being cleaved off of the T cell. This slide shows our currently available ART medications organized by class. You'll see that we have our nukes, our non-nuke, PIs, entry inhibitors, integrase inhibitors. We have pharmacokinetic enhancers, also known as boosters, and our multiple class combination tablets. These are also referred to as single tablet regimens. So now we'll talk more about these specifically in a bit. You'll also notice that every drug has a generic name, a 3-letter abbreviation, and a brand name. And we've had some new drug approvals recently. I've marked those newer agents with the new symbol, and you may have already seen some of these used in clients that you work with. So with all of these drugs and drug classes, how do we combine them together? It's pretty simple, actually. The DHHS guidelines tell us to initiate ART with one of these 3 types of regimens, either 2 nukes plus a non-nuke, or 2 nukes plus an integrase inhibitor, or 2 nukes plus a protease inhibitor, and specifically a protease inhibitor that is boosted with Ritonavir. So what does that mean? I will show you. This is something the pharmacists like to geek out on, so I apologize in advance. But this is a concentration versus time curve. And on one axis, you'll see that we have the drug concentration of the protease inhibitor. And on the other axis, we have the time from one dose to the next dose. And when we give an unboosted protease inhibitor, you'll see that this pink line represents the curve. The drug concentration rises after a person takes the medication, and then it dips down into this area of potential HIV replication too soon. But by boosting a protease inhibitor, shown by the blue line, by adding Ritonavir to it to increase the levels, we're able to increase the area under the curve, and we're also able to decrease the variability in the trough concentration. And that's important in HIV because we don't want the virus to replicate and we don't want it to garner resistance. So by adding Ritonavir to a protease inhibitor regimen, we're able to extend the drug levels for a longer period of time and make the drug. So this slide shows the recommended regimens based on the DHHS guidelines. And these are the regimens that are recommended regardless of a patient's baseline viral load or CD4 count. The plan is to initiate treatment with 2 nukes with either a ritonavir-boosted protease inhibitor or an integrase inhibitor or a non-nuke. And the preferred drug names are listed underneath each of their respective classes. So preferred NRTIs include tenofovir and emtricitabine. In some cases, we can use abacavir and lamivudine. Preferred protease inhibitors include atazanavir or darunavir, and of course boosted with ritonavir. Preferred integrase inhibitors include raltegravir, elvitegravir, or dolutegravir, and as noted, some of these are new to the market. The preferred NNRTI is efavirenz. So when you think about it, the model for selecting an ART regimen really follows the model of one of my favorite restaurants, which is Panda Express. And before you start laughing, let me tell you why selecting an initial HIV regimen follows the Chinese food rule. Instead of thinking about this in terms of preferred regimens, I think about it in terms of preferred Chinese food. And instead of 2 NRTIs, you get 2 scoops of rice. And instead of pairing the 2 scoops of rice with either a PI boosted with ritonavir or an integrase inhibitor or a non-nuke, you can think about it as beef enhanced with MSG or fish or chicken. And so just like Panda Express, where you go through the line and follow a stepwise approach, building an ART regimen follows those same basic rules. First, you get 2 scoops of rice. You choose 2 NRTIs, tenofovir and emtricitabine. And we try to use co-formulated agents whenever possible to decrease pill burden and improve adherence. You move down the Panda Express line and you choose your 1 main entree, beef, fish, or chicken. We decide which class to use, protease inhibitor, integrase inhibitor, or non-nuke. And how we make that decision is based on comorbidities, pill burden, drug interactions, or resistance testing. So PIs with ritonavir are like beef enhanced with MSG. Just like beef, protease inhibitors are very strong and very potent. It is very difficult to become resistant to protease inhibitors. However, just like beef, protease inhibitors have some metabolic effects. They can raise cholesterol or worsen diabetes, and they're prone to cause GI side effects like diarrhea. Protease inhibitors also have many drug interactions, and this can complicate their use. Integrase inhibitors are like fish because they're pretty well tolerated and they're easy to take, but they're sometimes thought of as delicate. Some of our integrase inhibitors, like fish, are delicate and it's very easy to get resistance to them. Dolutegravir, the newest agent in this class, does not seem to be as delicate or prone to resistance, so I would say that dolutegravir is a tougher, meatier, gamier fish, like salmon or swordfish, and the other integrase inhibitors are more delicate, like tilapia. And lastly, non-nukes are like chicken. They're like chicken because they've been around for a while and we know what we're getting each time, just like chicken. They're better tolerated than protease inhibitors too. But the thing about non-nukes is that it can be easy to develop resistance to them too, and their main side effect is rash and liver toxicity. And efavirenz, the recommended drug in this class, can cause birth defects and is contraindicated in the first trimester of pregnancy. So to summarize the main key points here, HIV management is driven by DHHS guidelines. The goal of ART is to achieve and maintain an undetectable viral load less than 20 to 75 copies per milliliter and an increase in CD4 count. It's important to monitor closely after therapy initiation for adherence, efficacy, and complications. Antiretroviral therapy is recommended for all patients regardless of CD4 count. Initial ART regimens consist of 2 nukes with a PI or an integrase inhibitor or a non-nuke. And this is just like Panda Express, 2 scoops of rice with 1 main entree. And ART really presents a tremendous opportunity for case managers to assist healthcare providers in patient counseling. I'd like to thank you for your attention to this webinar, and I'd also like to invite you to please join me for part 2 of this webinar, where we will discuss ART side effects, monitoring, and drug interactions. Thank you.
Thank you, Dr. Sherman. We really appreciate your presentation. Dr. Sherman, we have a couple of questions. The first question is, how do we differentiate between meds that are combinations of PI, entry inhibitors, etc.?
It was, how do you differentiate between medications or between regimens where they combine multiple classes of medications?
I believe that's what they're asking, but I'm not sure.
Yeah, so, the regimens that I reviewed here are what's recommended for initial treatment regimens, but often in cases of drug resistance or medication intolerability to one or more of these classes, we have to get creative in designing regimens. And there's no straightforward explanation. That's very individualized, and that's when we start combining some of these drug classes together, and we use protease inhibitors with integrase inhibitors or with entry inhibitors. And so those are like special case-by-case kind of scenarios.
Okay, thank you. Another question is, what do you consider a medical case manager's role in ARV management?
I can say that in the clinic where I work, which is a Ryan White clinic, we have 3 amazing case managers, and I feel like they've really taught me a lot about what the role of a case manager is. I see case managers as an ally to the patient and a liaison between the patient and the provider. Oftentimes, the case managers find out a lot more about what's going on in a patient's lives than the physician will. And, the patients will say that will swear up and down that they're taking their meds. And we're just baffled because the viral load is high and the resistance test shows there's no resistance, so the meds should be working, and they admit to the case manager that they're not. And so I think case managers do a great job of relaying information between the provider and the patient themselves. And they're advocates for patients too. So I've had case managers come to me and say, hey, so-and-so's having a hard time on all these pills. Could you look at their regimen and see if we could make it easier? And 90% of the time we can. I just never knew that the patient was struggling with so many pills. So I guess that's what I would say.
Dr. Sherman, thank you. Do you think that the role of the case manager should be to talk to you in person if they haven't want to share something with you, as to talk to the physician in person, or write a note, or who is the best person for the case manager to communicate the issues that they have addressed with? Is it the doctor themselves or somebody else?
Oftentimes the prescriber, unless they also work very closely with a nurse or a pharmacist, is, in the example of my clinic. But any way that case managers can reach out, I think, is important. So whether that be by calling or sending a quick email, or if you use the same electronic medical record to send an in-basket message, because oftentimes case managers document their interventions in a different system that providers don't always have access to. Okay,
great. Okay, we have several more questions. The next one is, some generic meds are now being released and insurance companies are preferring the generic versions. Is this the same? Not sure what that means. I'm assuming that most of the antiretrovirals are not generic.
Right, but I can tell you that I have a lot of patients that ask me about what is the true difference between brand and generic medications, and what I tell them is that this is highly regulated by the FDA and tested too by the FDA, and generic medications have to be pretty closely equivalent when we talk about the area under the curve. So when I showed you that concentration versus time curve, the way the drug gets released in the body and how much drug is released in a certain amount of time, it has to be very nearly equivalent to be a licensed generic. So essentially, they are the same medications. There are some differences in the excipients and the coloring and things like that, but usually, if you should get the same results from the generic as you do from a brand medication.
Okay, great. Okay, our next question is, this person says, I've spoken to some members who are not concerned about transmitting HIV since their viral load is undetectable. Do you have any talking points to better explain how HIV can still be passed along even though it is undetectable?
Yeah, that's a very good question. So what I always say is we know that viral load is undetectable because we're drawing blood levels. But just because viral load is undetectable in the plasma doesn't mean it's undetectable everywhere in the body, such as in semen and vaginal fluids. And I think that communicating that to patients is something that they never really thought about, or perhaps they didn't understand before. And it's true that being undetectable makes it much more unlikely to transmit HIV, but it doesn't make it zero, and I would never tell anyone that the risk was zero. So.
Okay. The next question says, is there a difference in the medication when it's in a combination therapy versus separate pills?
No, the only difference is when it's a separate pill, it makes it more difficult to take because patients have to take more pills, but there's no difference in the medication.
Okay. The next question is, I'm not sure if this is something you can answer or not, but why is it that some patients have an undetectable viral load continually carry a CD4 count below 200?
Yeah, that's a really good question. These are great questions. I like this group. So there is a certain subset of patients that are referred to as immunologic non-responders or immunologic non-progressors, and these are patients that for many years have an undetectable viral load, and as you said, we just can't get their CD4 count above 200. And it's very unfortunate because, we have to maintain them on PCP prophylaxis or they're at risk for other opportunistic infections and AIDS-defining conditions. It's not really clearly understood why this happens, but remember that antiretroviral therapy works by suppressing viral replication. It really does nothing to promote immunologic response. That's something that the body has to do on its own. So what I tell patients who fit this scenario is, you have to make lifestyle changes. Make sure you're getting good sleep. Drink water. Eat good meals, eat fruits and vegetables. Things that are like grandmotherly type advice, but might go a long way in helping the body to, stimulate its immune system functioning.
Okay. The next question is, on average, what percentage of clients obtain an undetectable viral load? I don't know if you can answer that one or not.
Well, I would say that 100% of adherent patients should achieve an undetectable viral load. I mean,
That's the key.
Right. As long as there's no viral resistance, if you're taking your medications every day, your viral load should remain undetectable. But I don't know a blanket answer, to that question.
Okay. I have another one that says, what are some medications that should raise a red flag when taken with ARTs for comorbidities?
The big ones that interact are protease inhibitors and anything that contains cobicistat, so like stribild as well, have a lot of drug interactions. Non-nukes do kind of as well. And concomitant medications that interact are statins, so some statins may be contraindicated for high cholesterol. Also, tuberculosis therapy with rifampin. Rifampin has a lot of drug interactions. Contraceptives, oral contraceptives, asthma medications, and inhaled steroids. There are just so many. The DHHS guidelines actually do a really good job, a really thorough overview of drug interactions with antiretroviral medications. Oh, also one that just popped in my head is like proton pump inhibitors, H2 blockers, antacids, also have a lot of drug interactions.
Another question is that, we look at you mentioned earlier that it doesn't, regardless of the person's CD4 count, and how high it is, that you should start antiretroviral treatment. And one of the questions is there new guidelines out for CD4 testing that say you don't have to do that every 6 months, but that you can do it annually now? And if that's the case, does that impact the antiviral treatment that patients are on, and should it be done more frequently?
So yeah, there is new. So in the past, we usually would check someone's CD4 count like every 3 to 6 months. And yes, there is new guidance available saying that patients who've maintained an undetectable viral load for at least 2 years and their CD4 count has consistently stayed above 300, that you can start monitoring their CD4 count annually. But those would be patients who are on ART. So the decision to initiate ART doesn't necessarily impact the decision to how often you're going to be monitoring ART, because the patient still has to hit that endpoint of virologic suppression, maintaining an undetectable viral load for a period of at least 2 years before you start extending the monitoring frequency of CD4 count.
Okay, great. Another question is that I have seen some patients that suffer stronger side effects than others. Is there a relation between side effects and drug resistance?
Well, I would say that patients who, the relationship would be this: patients who develop side effects to medications don't want to take those medications on schedule because they don't want to feel crummy. And so if you start skipping doses of meds, then you can develop resistance because you don't have adequate drug levels in your body.
Okay. The next question is, what are the impacts of medical marijuana?
You know, I have a lot of colleagues that live in Colorado where they have recreational marijuana, and I ask them, you know, what do you say to your patients? And, you know, we talked about it, and the thing is, anything that you inhale into your body, marijuana or cigarette smoke, any of that, it causes inflammation in the lungs. And any type of inflammation in our body isn't good. So is there any direct consequence of marijuana on antiretroviral therapy efficacy? No, there's no contraindication there, but could using marijuana make you forgetful and make you not remember your medications? Yeah. And could using marijuana or anything that causes inflammation in the body lead to adverse consequences in the long run? Certainly. And is HIV a catalyst for that? Yeah, absolutely. So I think that's the simple answer to a not so simple question.
Okay. The next question is that if a client is given a regimen and is adherent to only one portion of the regimen, how do you know which one they are taking if you're not told?
That's a great question. You don't know. I mean, eventually what will happen is if they're taking only partial, part of what they're supposed to be taking, part of the regimen and not other meds, they'll become resistant to the ones that they are taking. That's what will happen in the long run because, like I said, just taking one medication is not effective to control the virus, and the virus will overcome this with resistance.
Do you know of any new drugs that are coming down the pipeline right now?
Sure. There's Cobicistat is a booster. It's a boosting medication, and it's going to soon be co-formulated with some of our popular protease inhibitors. So there's going to be a tablet that's going to have Darunavir and Cobicistat and Atazanavir and Cobicistat, so those co-formulated together. So that's not a new drug, but it's kind of new formulation of existing drugs. And then I think the most promising new drug that'll come out in the next year or so is a new version of tenofovir. So you saw that tenofovir was a preferred NRTI, but its limitations are that it can cause kidney toxicity and it can also cause bone, like osteoporosis. So there's going to be a new version of tenofovir called tenofovir alafenamide, and it's supposed to have less of these toxicities. So I don't think there are any brand new drugs that should be hitting the market that are going to, revolutionize everything, but maybe some co-formulations and reformulations of existing medications.
Okay. It says, the next question is, of the top new drugs, are there any vaccination updates?
The HIV vaccine is something that I think everybody would like to see happen and be a reality, but the truth is it's really nowhere near ready for prime time. I think we've had one promising clinical trial where it worked, and that's one out of multiple where it didn't work or it even caused people to get HIV, not prevented it. So I think we're just now embarking on beginning to understand how HIV vaccines work or might work. So I would say it's a possibility. Anything is possible, but nowhere near something that we're going to see in the next couple of years.
Could you please be more specific with regard to the difference between NRTIs and NNRTIs? I realize that both block the reverse transcription process, but what exactly is the difference?
Yeah, that's a very good question. So if you think back to your chemistry courses that you took when you were in high school, DNA, it's got these base pairs, these two pairs, right? So made of A, C, T, and G, these pairs of amino acids. So the way nukes work is they incorporate false nucleic acid sequencing when that piece of RNA is being formed into the DNA. So I like to think of nukes like they put, so when DNA is going to RNA, it's like two pieces of a zipper come together and they're being zipped up. And reverse transcriptase is the enzyme that zips them together and makes that double helix of DNA. So NRTIs work by incorporating false nucleic acid sequences. It's like they put kinks in that zipper. And so if they put kinks, then the zipper can't zip up. NNRTIs, non-nucleoside reverse transcriptase inhibitors, work by simply just blocking the enzyme. So the enzyme is not effective. So you get the two sides of the DNA, but they can't wrap around each other. It's kind of like pulling the handle off of the zipper. And so, AAHIVP, for example, is a single tablet regimen that's 2 nukes plus 1 non-nuke. And I like to think of that as, if you are, let's say you're camping and it's very cold outside and you're in a sleeping bag and you've got like one kink in your zipper, you're going to pull that zipper as hard as you can to get it to come up because you're cold and you want it to come up, and you'll be successful. One kink in a zipper isn't enough. But if you were to put a kink in the zipper and take the handle off the zipper, you'd probably have a really hard time. And that's why, we combine medications, we use multiple drug classes that work in different ways, and that's the difference between nukes and non-nukes.
That's the best explanation I've ever heard. Thank you, Dr. Sherman.
Thank you.
We have time for one last question, and it says, as a medical case manager, if I notice that my client is on some drugs that have been around forever, should I discuss with them about the new drugs?
I'm a big fan of if it's not broke, don't fix it. But I also am a fan of making things easier for patients. The DHHS has a table in the guidelines that's called the do not use list. And so I would say if any patient is taking a medication that's on the do not use list, which is things like didanosine, stavudine, some really old drugs that haven't been around for a while, that would be a reason to talk to the provider about updating the regimen. And if they're having problems with it too, if they're having problems with their medications, peripheral neuropathy or, just aggravated diabetes or any issues, that should be brought to the provider's attention, and difficulty adhering to multiple pills also. You easily simplify. I love it when the case managers come and ask me if we can make it easier, because it's not something that I'm always thinking about.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, FCAETC.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.